Hey, good evening, everyone. I want to welcome you to our presentation tonight. We're going to start in just a moment, but we want to allow our guests to join in. So we'll wait a few seconds here. We're just saying it's been a hot and humid day, kind of stormy out, so hopefully we don't get interrupted. So I do see people joining, but we still need to give another minute. For those who are just joining, we're waiting for other people to join us as they log in. So we'll be starting the presentation in just a moment. Okay. We'll allow others to join as we go. So I would like to say good evening to everyone. My name is Chris Malloy. I'm a certified financial planner and senior advisor at TMFD Financial. I'd like to start off by thanking you for joining the webinar this evening. In a moment, I will introduce our speaker, Dr. Matthew Galli. First, I'd like to briefly introduce TMFD Financial and explain the valuable services we provide to clients. Our goal is to make the financial lives of our dentists simpler by combining a variety of services under one roof, from tax, investments, insurance, and other financial planning matters you may have. In our experience, we found that providing a one-stop shop for financial solutions provides clients with the comfort of knowing that all aspects of their financial careers are synchronized. The result is simplicity, peace of mind, and confidence in your financial decisions. Now, for those that are new to TMFD, I wanted to mention we're offering a complimentary dental practice assessment and financial review. This process highlights the financial health of your practice, identifies areas of excellence and areas for improvement, as well as an estimate value of your practice. This is a service we offer to all existing accounting clients. So if this is of interest, feel free to take advantage of this complimentary offer. More details will be provided in an email following this presentation. So at this point, I'd like to hand things over to my colleague, Jake Giesler, who's managing the technology for us, and to provide some housekeeping items.
Thanks, Chris. Good evening, everyone, and welcome to the TMFD Dental Academy. My name is Jake Giesler, and I'm also an advisor here at TMFD Financial, and I'll be running the tech in the background. Before we get started with this evening's presentation, I just want to take a quick moment to run through some housekeeping items. This webinar is scheduled to go to about 8:30 p.m. And if you have any questions for Dr. Galli during the presentation, please ask them in the Q&A section at the bottom of your screen, and they will be answered throughout the presentation. If you have any questions for me or Chris, or something you just like to chat in the chat box, please feel free to send that chat. If during the presentation you have trouble viewing our webcams, please let me know and I can assist. Category 2 CE credits will be sent out within 2 weeks. You can expect them no later than July 5th. And lastly, we encourage you to register for our TMFD Academy mailing list so you can stay up to date with all of our upcoming webinars. I will send a link to that in the chat box, and that's all I have for housekeeping items. So with that, I'll give it back to you, Chris.
Perfect. Thanks, Jake. Okay, so I'm really pleased and excited to introduce our speaker for this evening, Dr. Matthew Galli. Dr. Galli completed his dental degree at University of Toronto and then graduated from the University of Michigan with a master's in periodontics. Dr. Galli practices in Mississauga, and he's had the good fortune to work alongside his father, Dr. Guido Galli, and has become an integral part of the team. Matt has given many seminars and presentations, teaches at U of T, and has been published on numerous occasions. During his talk, Dr. Galli will share his insights and philosophy around evidence-based treatment protocols. And on a personal note, I've had a chance to get to know Matt and his family over a number of years, so I know he's passionate about the work that he does, but he's also a genuine and humble guy. So Dr. Galli, from all of us here at TMFD, we'd like to thank you for your participation. And
Oh,
with
it's my
that, I'll
pleasure.
turn things over to you.
It's awesome to be here with you guys tonight. I'm going to share my screen in a second here and we'll get started. Can you guys see everything?
Looks good.
Perfect. Let me just 1 second minimize this. All right, awesome. So it's great to be here with you guys tonight to talk about a topic that I'm passionate about. I'm going to discuss with you contemporary approaches for soft tissue grafting around teeth. I'm excited to share with you some examples of my cases and my insights on this topic. Feel free to interrupt me anytime during the presentation if you have questions, and I'd be happy to discuss any elements of the presentation with you. And so before we get into the presentation, I just want to give a little bit of an introduction of some different things that are important to me. So this here is my work family. You can see this is our team here at our Mississauga office. I think this was during somebody's birthday celebration where we had a chance to all take a photo together, which was nice. And then this is me and my fiance Heather during our recent vacation in San Miguel in the Azores, where we had an awesome time together there. I'd highly urge you guys to visit it if you haven't had a chance. It's a really, really beautiful spot and it's not so far away. And so first thing I want to talk about is how to identify mucogingival defects. So this is a case that presented to our clinic that I treated, and you can see here, patient has some significant recession in the presence of thin tissue, minimal attached gingiva. They also have an aesthetic concern. So these are the common problems that patients present with when they're in need of soft tissue grafting and when they have mucogingival defects. And these are kind of the things that you have to be thinking about when you're diagnosing them and deciding when something should be monitored versus treated. And so recession, as I'm sure you're all aware, it's measured from the CEJ to the gingival margin. And so minimal attached gingiva. First off, how do you identify the mucogingival junction? This is a really important thing. One of the easiest ways to identify is to use something called the roll technique, where you take a probe and you basically position it horizontally, and basically the junction between the movable and non-movable tissue is basically the mucogingival junction. And so that's just an easy way to identify that. So here you can see there's minimal attached gingiva. And so attached gingiva, how do we define that? Attached gingiva is basically the keratinized tissue width measured from the gingival margin to the mucogingival junction minus the probing depth. And so minimal attached gingiva is when the probe tip extends to or past the MGJ, which is the mucogingival junction. And from some classic literature, we know that 2 millimeters of keratinized tissue width is important for gingival health. And in general, just a rough cutoff that you can use is you would like to ideally have about 2 millimeters of keratinized gingiva or 1 millimeter of attached gingiva to help maintain health. And so this is how I treated this case. I treated it with a connective tissue graft. So here you can see I raised a trapezoidal flap and I basically secured a graft with a periosteal suture. And you can see here how it healed at a couple months. And so just a before and after, this is basically the outcome that we see here is we were able to treat the recession with some root coverage, able to successfully thicken the tissues, and also able to increase the zone of keratinized tissue. And so I'm going to be going through a few other cases in a moment, but I just want to spend some time discussing the etiology of recession. This is just an important starting point for us to discuss. So recession, it's really at the heart of it, it's due to bone loss. You're never going to have recession unless the bone has already left the building. So anytime you have recession, it's really also important that we not only talk about soft tissue, but that we also talk about bone. Because if you have thick bone, you're not going to have recession. You're really only going to get recession when you've had bone loss in the area. And the two main triggers are going to be chronic inflammation from either trauma or microbes, which cause a loss of supporting bone and apical migration of the gingival margin. And so here we can see a toothbrush is one of the most improper toothbrushing technique causing trauma, or traumatic toothbrushing is one of the major causes for recession. In addition, chronic inflammation from bacteria and microbes, either in the form of periodontitis or just plaque-induced inflammation in certain areas, is also a really important cause of recession as well. And so there's two main types of patients that we're going to see who have recession. One of them is going to be our periodontal patients. So as part of the pathogenesis of periodontal disease, you're going to see significant recession in a lot of cases. And then other patients that are going to have normal, healthy sulci with non-disease interdental bone, but they're going to have recession. And a lot of times these are the patients that have really good oral hygiene, but maybe overdoing it with the brushing. And so when we talk about recession, it's important that we differentiate between predisposing and precipitating factors. So this is from one of the classic articles on the topic. I've cited it down there at the bottom. There's a couple articles that you can read in more detail if you're interested. But basically, predisposing factors are the factors that basically, as in the name, predispose towards gingival recession and mucogingival defects. So they're kind of things that you're born with or things that are inherent to the person's biology, versus precipitating factors are going to be more so things that will modify the risk of disease and modify the risk of recession progression. So predisposing factors, some important ones include inadequate attached gingiva, thin mucosa, frenal pull, malpositioning of roots, root prominence, and bony dehiscences. Precipitating factors, there's kind of two main subcategories. One of them is the pathologic. So we're looking at trauma from improper home care, piercings, direct trauma from malocclusion, somebody with a deep bite, for example, where their teeth are physically contacting the gingiva, resulting in trauma or lacerations. In addition, periodontal disease and some forms of desquamative gingivitis can also be associated with recession. And then physiologically, one of the major risk factors is orthodontic movement of teeth outside the bony housing, and we'll kind of circle back to that later on in the presentation. And so when I discuss toothbrushing with patients, the main advice I usually give in order to limit the risk of trauma is, firstly, I describe to patients it's a toothbrush, not a gum brush. I mean, I know this sounds kind of silly, but there's a lot of patients who actually think that they need to stimulate or massage the gums with their toothbrush. And so it helps to just tell them this, that they're not supposed to do that. Really, the most important overlying and overarching principle is to be gentle. You want to have a gentle touch when you're brushing. It's not like you're polishing a table, but more so that you're just disrupting the formation of the biofilm, which is very soft. You want to use soft or extra soft bristles. And if you're using an electric toothbrush, you want to let it do the work for you. In other words, you don't want to add in any additional scrubbing motion or additional force. And so let's talk a little bit about the periodontal phenotype and what different variables play a role in determining this. So periodontal phenotype, what are the two main supports for the teeth? Really what it comes down to is that it's important to look at both the bony support and the soft tissue support. When we're looking at the soft tissue, there's a few different factors that are important to consider. One of them is the level of the gingival margin. Another one is keratinized tissue width. Another one is gingival thickness. And you're going to see that with soft tissue grafting, we're able to modify all three of these. What we're not able to modify is the alveolar bone thickness or the level of the alveolar bone. And so it's not predictable to grow bone around teeth, but what can be done is we can augment the soft tissue to compensate for the fact that we've lost bone. And so that's a really important distinction to explain. And so as you can see here, what we're able to modify with soft tissue grafting is the gingival margin, the keratinized tissue width, and the gingival thickness, not so much the alveolar bone. And so this is just actually, but you'd be surprised to see a picture of a pantyhose in a dental presentation. But it's just one of the analogies that we actually heard from one of our hygienists, which we found was helpful for explaining, especially to female patients, how soft tissue grafting works and how it can basically help with treating mucogingival defects. And so basically the way that I typically explain this to patients is that I say, in the olden days when women would get a tear in their pantyhose, they put a little bit of nail polish at the end of the tear. Now, this nail polish, it's not going to reverse the fact that there's a tear there. In other words, we can't get back the bone that you've lost. But what we can do is we can reinforce the area by thickening the soft tissue and improving the quality of the soft tissue so that the tear doesn't progress and get any worse. And so this just really highlights at the heart of it what we're trying to do with soft tissue grafting. If you guys have any questions about how to better explain this to patients or how to explain it to patients in more detail, just let me know. I'd be happy to provide more insight on that. But it's just a helpful analogy. And so let's pull up the first question on the poll. This is in regards to the etiology of recession. Buccal recession is always associated with loss of the buccal plate, true or false? And then Chris, I'm not sure if I'm supposed to end the poll or if if you guys are gonna end it.
I'll end the poll.
Perfect. And then just let me know when I'm good to proceed.
Awesome. Yeah, looks like you're good to proceed.
Very good. All right. I don't have access to my cursor, so I don't know if I can, give me 1 second. Wait, there we go. That's better now. I don't know why. Oh, it's kind of weird. Anyways, I kind of lost control over my cursor and the ability to flip back and forth between the slides, but we'll just continue with this slide. And so let's ask ourselves the question, does keratinized gingiva contribute towards health? So this is a classic study done by Kennedy and with Dorfman as the one of the primary authors as well. And basically in this study, they found patients with a bilateral lack of buccal attached gingiva, 32 patients with 6 years of follow-up. And basically what they did was a split mouth design where they treated one of the sides with a lack of attached gingiva with a free gingival graft, and the other side they left untreated. And then they provided a maintenance program of 3 to 6 months for all the patients that were included. And so every patient was coming every 3 to 6 months for maintenance. However, not all of the patients were compliant with maintenance. Some of the patients were non-compliant. A certain population didn't listen to the maintenance instructions and didn't really have a great plaque control. And so this is going to basically highlight the role that free gingival grafting can have. There we go. And so the main point that I really want to make is that what we can see here is that compliant patients that were treated with the free gingival graft had reduced recession and greater extent of keratinized gingiva. Non-compliant patients that were treated with the free gingival graft, they had no change in recession, versus patients who were not treated with the free gingival graft, so they still have a lack of attached gingiva. If they're non-compliant, the recession increased. And so attached gingiva is important to maintain gingival health in patients with suboptimal plaque control and maintenance irregularly. In this case, a lack of keratinized gingiva predisposes towards attachment loss. So it's especially in a subpopulation of patients who aren't having good plaque control, who aren't going for regular maintenance, who aren't compliant, which tends to be a lot of patients who can have a tendency to have certain periods in their life where they drop off from maintenance, where they don't necessarily pay as much attention to their oral hygiene. In these moments, especially, a lack of keratinized gingiva is really going to predispose them towards attachment loss. Here's another study, which is an interesting study where they basically did a longitudinal analysis of 6 randomized clinical trials with a minimum of 10 years follow-up. And what they found was that obtaining a gingival thickness of 1.5 millimeters and keratinized gingival width of at least 1.5 millimeters 6 months after soft tissue grafting treatment was shown to predict a stable level of the gingival margin over 10 years. In other words, if you have this minimum amount of keratinized gingiva and gingival thickness, the level of the gingival margin should remain stable and recession shouldn't progress. And so this is really showing that having thick gingiva, having keratinized gingiva is protective in the long term. And so this is just a little bit of a decision tree for in terms of treating versus monitoring recession. So if you have a patient and they have a lack of attached gingiva and or thick tissues, is recession present? If it is, maybe wise to consider soft tissue grafting. If not, you may monitor it. If orthodontic treatment is planned, you may want to consider soft tissue grafting prophylactically in certain situations, depending on the direction of tooth movement and the direction that the roots are going to be moving, just to help prevent the initiation of recession and attachment loss in that area. And so what are the goals of soft tissue grafting? And so some of the major goals, and this really is also dictated by the type of approach that you use, but in general, the goals include deepening the vestibule. Deepening the vestibule can improve retention and comfort of a prosthesis, for example, a denture, can improve access and comfort for oral hygiene. I'm sure we've all seen patients with a shallow vestibule with a lack of attached gingiva, and they have a bunch of plaque on their teeth, and it's oftentimes because they find it uncomfortable to brush. It can also help to reduce food impaction. Increasing the keratinized gingival width will help to preserve gingival health in the absence of maintenance. Increasing mucosal thickness will help to resist trauma, inflammation, and subsequent recession, and also offers greater long-term stability. And then root coverage. This is important primarily from an aesthetic perspective, but also helps with reducing hypersensitivity. and is also an important way that you may possibly approach treating non-carious cervical lesions like abrasion and abfraction. And so it's not just through a restorative approach. Soft tissue grafting may be combined with restorative approach to help treat these lesions. And I'll go through that in more detail later on. And so here are really the major techniques that are used in terms of soft tissue grafting. One of them is the free gingival graft. So this is the most predictable way to increase keratinized tissue width, eliminate aberrant frenal attachments, can be used for root coverage in areas where aesthetics are not a concern, for example, the anterior mandible. The main disadvantage of this is that it has a tire patch appearance where it doesn't blend as well with the adjacent tissues. So it's more noticeable that work has been done. And in cases of root malpositioning outside the bony housing, connective tissue graft is oftentimes the better choice. Connective tissue grafts, the main advantage is this is really the gold standard for improving tissue thickness and root coverage. It blends seamlessly with the adjacent tissues, so it's very aesthetic. Its disadvantage is that it's technique sensitive, not as predictable for increasing keratinized tissue width. And then we also have our tissue substitutes, which come in the form of allograft and xenograft. And so the benefit of this is it avoids a second surgical site. There's less pain and discomfort during healing. They can be used for tissue thickening and root coverage, and they do blend very seamlessly with the adjacent tissues, offering good aesthetics. Disadvantage is this is also very technique sensitive and it's unpredictable for increasing keratinized tissue width, and it has the highest risk for recession recurrence long term. Autogenous tissue, which contains your body's own cells, is going to have the best long-term outcomes in the majority of cases. And any exposure of the graft during early healing for an allograft or xenograft can lead to a much higher risk for infection or failure. And so let's talk about some of the factors that are important in terms of affecting root coverage and when root coverage predictability is higher versus lower. And so really the major factor that is important for predicting root coverage is the interproximal attachment levels. So if you have no interproximal attachment loss, this is going to be much more predictable than if you have significant interproximal attachment loss. In such cases, root coverage becomes very unpredictable. Other very important factors are root malpositioning and the presence of a non-carious cervical lesion. So the more malpositioned the roots are, and the larger the non-carious cervical lesion, the less predictable it also becomes. And so this brings us to our second poll question. The goals of soft tissue grafting can include the following, and I'll leave it up to Chris to bring up the poll. Is it okay if I can continue now?
Yeah, absolutely.
I think that, Matt, if you can explain the result of the poll, because I don't think everyone can see the results.
Oh, sorry. Okay, yeah. So for the first one, it was that basically recession is always associated with bone loss. You're never going to have recession unless the bone has left the building first. And so that's why it's also very important to realize that recession is not only loss of soft tissue, it's also loss of bone. For the second question, it's all of the above. All of the above are important goals for soft tissue grafting, and different techniques stress different factors from this list. Right. And if there's ever any questions, you guys just let me know because I can't actually see anything else besides my my presentation. I'm
Certainly
happy
no
to.
problem.
Awesome. All right, so let's continue. So let's talk a little bit about the mucogingival management of non-carious cervical lesions. And so here I picked 3 different cases, all in the same anatomic area, different patients, different cases that I treated. And you can see that all these patients, they have a combination of both non-carious cervical lesions, which is abfraction and abrasion, in addition to soft tissue defects. They have recession, they have thin tissues, they have a lack of attached gingiva. And so let's think a little bit together how we can approach these cases, because this is something that we're all going to see. It's very common. And so the incidence of non-carious cervical lesions in association with recession, it's about 50% of the time that you're going to see that gingival recession is associated with a non-carious cervical lesion. In these cases, a combined surgical and restorative approach may be needed. Some of the restorative treatment options include resin-modified glass ionomer or composite resin. And so my personal preference is to, if we're considering to do soft tissue grafting and a restoration, my personal preference in terms of the order of events and the chronology in terms of the steps that we take is to actually do the soft tissue grafting procedure first, and then to do the filling afterwards. Because as we'll see in some of the cases, we can see that sometimes we can actually limit the size and extent of the restoration by doing a soft tissue graft beforehand, versus if we estimate the size of the restoration beforehand, it'll limit basically our ability to get root coverage in that situation, because soft tissue grafts in general, they don't have a great ability to extend onto the surface of a restorative material. It's much better to have it on dentin and cementum versus on a restorative material. It's not going to stick to it. And if we are going to do the restoration before the soft tissue graft, there's a rule called the CEJ+1 rule. And I'll just, this is from an article that basically talks about this. And what you can see here is what they did is they reconstructed the CEJ, because in a lot of these cases, the original position of the CEJ is basically, it's destroyed. You don't know where the original CEJ was. A lot of times you have to kind of estimate where the CEJ was and recreate it with your restoration. And so what they recommend is that you estimate where it is, and then you go 1 millimeter apical to that. So the CEJ+1. So that just means you go 1 millimeter apical to that, and that would be the most apical extent of your restorative material. And then afterwards, you can do a soft tissue grafting procedure, and this just helps with limiting basically exposure of the restorative margin. And so here is one of the cases I was showing you that I treated. And for this case, let's look at the problem list. And this problem list I'm going to put for all the cases that I'm showing you that I treated. And basically, it's just how you can think about the different variables that are important in terms of determining when treatment would be beneficial in terms of soft tissue grafting. So here we see there's thin tissues, there's minimal attached gingiva at 4-4, there's significant recession, there's non-carious cervical lesions with loss of the cemento-enamel junction. And so I harvested a connective tissue graft. Here's how the palate was treated. And then I sutured the soft tissue graft in place. And here's the final suture. And then we can see 3.5 months later. And if we just compare the initial situation to 3.5 months later, you can see that actually in this case, if you had done a restoration initially, it would have limited actually the result that would have been attainable with soft tissue grafting. And so in this case, actually, no restoration would actually was even really needed. And so this just goes to show that sometimes it's beneficial to do the soft tissue graft first, see what you're able to get, and then afterwards see if a restoration would be beneficial. Here's another case, same anatomic area, similar situation. Here we can see there's thin tissues with minimal attached gingiva, 4-3, 4-4, 4-5, significant recession at 4-4 and 4-5, non-carious cervical lesions at 4-4 and 4-5. And so this case I also treated with the connective tissue graft. This just shows what the graft looks like after I harvested it. I sutured it in place with some microsurgical sutures. And then here we're able to see 3 weeks, how the healing was. And 3 months later, we can see we were able to gain significant tissue thickness, great outcome in terms of root coverage as well. And we're able to see the before and after here. And then here's another case I want to show you guys. Very similar situation, same anatomic area. You can see there's thin tissues with minimal attached gingiva at 4-4, 4-5, and 4-6, significant recession, non-carious cervical lesions. And it was also treated with soft tissue grafting via tunneling approach. And we can see here at 3 weeks and 2 months. And then here, now we can see that the patient could receive restoration on the 4-5. At this point, it would really limit the extent of the restoration compared to if you had restored it before. And so let's talk a little bit about management of non-carious cervical lesions, and this is going to bring us to our third question. And so non-carious cervical lesions in the form of abrasion of fraction are best treated only with the restorative approach in all cases. Is this true or false?
Sharing the results with you all now.
Nice. Everybody got it correct.
Perfect.
And so let's continue now. Is it okay if I continue?
Yep, go right ahead.
All right, thank you. All right, so let's delve into a little bit of a different topic. Also a very, very common clinical situation that happens in practice on almost a daily basis. Mucogingival management of orthodontic patients. And so there's two possible situations. One of them is the patient's contemplating orthodontics, and they either have some thin tissue, recession, minimal attached gingiva, and we're worried in these cases oftentimes that we're going to be worsening the extent of the recession depending on the movement of the teeth. And so how do we manage these cases? What are the important variables to look at to determine risk? And how do we determine the risk that these patients will have future attachment loss, and how do we prevent that from happening? And then the other situation is patient who's either in the middle of orthodontics or after orthodontics is completed, and we notice that there's a mucogingival defect that's present. And so how do we handle these cases as well? And so I'm going to talk about both of those things. And first, I'm just going to kind of provide some guidelines. And so a pre-orthodontic periodontal assessment can help with planning and prevention of mucogingival and periodontal complications. And so some of the important factors that I use in terms of determining the mucogingival risk is what is the direction of planned root movement? And so if you're planning to move teeth in the same direction as an area that has thin tissue or a pre-existing mucogingival defect, then it's very logical that that is going to be a high risk situation for a progression of basically the recession or mucogingival defect that's present at that site. So the direction of the planned root movement is really important to consider. Versus if you were going to actually move the tooth lingually and there was a recession at the buccal, the lingual tooth movement may actually help with reducing the size of the recession there and may actually even help to provide more predictable treatment after the root movement is completed. And so the direction of the planned root movement is important to consider. Gingival phenotype. So how do we determine gingival phenotype? Really what we're thinking about is, do the tissues, are they thick or are they thin? So here we can see they're quite thin. One thing that you can actually do is you can actually put your probe inside the sulcus. And if the probe is able to be visible through the soft tissues, that's a good way to know that the tissues are thin. Versus if it's not visible, oftentimes that's a good indication that the tissues are a little bit on the thicker side. And so also in terms of keratinized gingiva, usually we would like to see at least 2 millimeters of keratinized gingiva. And also, are there any pre-existing mucogingival defects? Does the patient have any pre-existing recession? What's their oral hygiene habits like? What's their brushing technique? Are they traumatic brusher? Do they have evidence of of abrasion from toothbrushing? How's their plaque control? Are they keeping good plaque control? Are they cleaning their teeth effectively, or do they have a lot of areas where there's a significant supragingival plaque? Are they causing trauma, as I mentioned? And so these are really the important factors I use to basically think about the mucogingival risk of the patient going into orthodontic treatment. And so here's a case that I saw patients planning to have orthodontics done. They have some recession that's present, thin tissues, and they have interdental bone loss. So that means they have interproximal attachment loss. They have prominent roots. And so for this case, I decided to treat with a free gingival graft prior to the orthodontic therapy to help limit the risk of recession. And so here's what the graft looks like after I harvested it. And then what I did is I made some slits in the graft so I can almost stretch it out like an accordion. So this just limits the size of the graft that I need to harvest. You can see that the graft, it's not a huge graft. I was able to harvest a smaller graft and kind of stretch things out so that it just minimizes the trauma to the patient's palate. And then here's how it looks at 2 weeks of healing. And here's at 2 months. And then here's the before and after. And so we can see that I was able to successfully increase the zone of keratinized tissue. I increased the tissue thickness as well. And so even if these teeth are going to be moved buccally, there's a much lower risk now that you're going to have a significant recession after the orthodontic treatment is completed. And so this patient, it's another important thing I like to talk about. So what happens if you have a patient with recession everywhere and they're going to go through orthodontic treatment? Oftentimes, I would just focus on the area where we're expecting the most buccal tooth movement. In this case, it happened to be the lower anteriors. And I would just treat that area before, because the last thing I want to do is overwhelm the patient with a bunch of soft tissue grafting before they're already going to go through an extensive orthodontic treatment plan. it's much better in this case to just pick the area that you think it would have the greatest benefit. And then what I usually say to these patients is we'll circle back after your ortho is completed and we'll see if the other areas require treatment. And so there was other areas that we're going to plan to treat, but we're going to do it after the orthodontics is completed. That way we're not overwhelming the patient. And then here is a situation where another very similar situation to the other one I showed you. Very common situation that I see on a daily basis. Advanced recession at the lower anteriors, interdental bone loss. The patient's planning to go through orthodontic treatment. The clinicians who referred the patient were worried about the thin tissues, the prominent roots, the minimal attached gingiva, the frenum pole, and we just wanted to make the situation better so that we reduce the risk of inducing further attachment loss. And so a free gingival graft was also conducted here. And then here's what it looks like at 3 weeks and at 2 months. And let's have a before and after. So here we can see we were able to successfully achieve some root coverage, which was great. We were able to thicken the tissues and also increase the zone of keratinized tissue. And so this is going to provide much better protection for the long-term stability of this patient. And so here's another case. Patients contemplating going through orthodontic treatment, buccal tooth movement is planned. There's significant recession there. And there's interdental bone loss that's present between the 3-1 and 4-1, thin tissues, prominent roots, minimal attached gingiva, frenum pole. And so for this case, I treated with a connective tissue graft via a tunneling approach. I used microsurgical sutures to hold everything in place. And here's what it looks like at 2 months. And here's the before and after. You can see we're able to increase the zone of keratinized gingiva, increase the tissue thickness, provide a much more stable situation for this patient. Once they go through orthodontic therapy, they're not as likely to experience any complications in terms of increasing recession or anything like that. And so this is a patient who was partway through orthodontic therapy when I first saw him. And I decided to wait till the orthodontic therapy was completed before doing the treatment. But we can see here that there is a wide, deep recession at 3-1. There's no attached gingiva. The tissues are thin. And so here's what the free gingival graft looks like after I harvested it. Here's what it looks like sutured in place. And then we can see at 3 weeks, 2 months, and before and after. And so this is going to provide a much more stable situation for this patient moving forward. And it's basically going to allow them to have more also comfort when they're brushing that area, because before it was uncomfortable for them to brush with the thin friable tissues that were present. And so just another similar case. You can see a lot of these cases are the lower anteriors because this is one of the most common areas that we treat both pre and post orthodontically. So I thought it would be the most relevant to show. And here we can see there's wide, deep recessions at 3-1 and 4-1, a lack of attached gingiva and thin tissues. And this is from a bird's eye view. So when you're assessing the gingival thickness, also give the case a look from this view, because here you can really clearly see the root positioning. You can see that at the 4-1, the root's very prominent. The tissues are super thin there as well. And you can see that the root at the 4-1 is actually buccally inclined, which is predisposing that one towards a more significant mucogingival defect. And so this root is actually proclined outside the bony housing, which is why there's a significant recession that's present. And so I treated this case with a connective tissue graft. And you can see at 3 weeks. And here's at 2 months. And here's another view at 2 months. You can see the nice thick tissues that I was able to establish there. Really going to provide a more stable situation for the patient. And before and after. And so you can see how soft tissue grafting can really help to improve the situation for our patients. And so now let's talk a little bit about post-orthodontic connective tissue grafting. And then we're going to go through some other examples. I think I just have a couple more examples of this. And so here we can see there's a very prominent root. It's outside the bony housing. There's moderate recession that's present, thin tissues, minimal attached gingiva. And so I did a connective tissue graft at this site, secured it in place with microsurgical sutures. And you can see at 3 weeks how it looks. in 2 months. And you can see there's a nice thick band of tissue there now. You can see I outlined it here, nice thickness there. And this is really going to help protect this area moving forward. And then last, I think this might be the last one for orthodontics that I'm going to show, and then we'll move on to a slightly different topic. So severe recession, thin tissue, no attached gingiva, prominent roots at 3-1 and 4-1. Again, look at it always from a bird's eye view. Helps to look at the inclination of the roots in the buccolingual dimension. You can see here, you can literally see the roots shining through the tissue, which is an indication that there's little to no bone that's present there. So these roots are outside the bony housing. And here's what the connective tissue graft looks like right after I harvest it. Here's how it looks sutured in place. Here you can kind of get an idea for how I secure everything in place. I use a combination of buccal and lingual slings. I also use lateral fixation with polypropylene sutures, and then I also do a combination of intrasulcular and vista tunneling, which means I tunnel from the sulcus and from a vestibular incision. And here's how it looks at 3 weeks. And then from the bird's eye view, we can see we established a nice thick collar of tissue around both those teeth. And here's how it looks like at the before and after. And then here you can see you can't see the roots anymore shining through the tissue. There's now a nice thick abundance of tissue there that's going to protect the remaining bone that patient has, so that hopefully they don't lose more bone, they don't have worsening recession over time. And then just one more similar case, moderate to advanced recession, lower anteriors and premolars. You can see thin tissues, minimal attached gingiva. I secured this soft tissue graft in a similar fashion to the other cases, microsurgical sutures, tunneling approach. And then we can see at 2 months, you can see the thickness that we gained. We can see the different situation between the initial presentation and after 2 months. There's much more thickness there, which is really going to help prevent worsening of recession over time. And so let's talk a little bit about plaque-associated mucogingival defects. And so a lot of times on the site, if you have an isolated deep recession, you're oftentimes going to see with isolated deep recessions that there's a lot of plaque at that area. And why is this? It's because oftentimes it's just a very uncomfortable area for patients to clean, and it almost becomes a self-perpetuating positive feedback loop where you have the worsening recession. The worse the recession gets, the more plaque that accumulates because they feel uncomfortable to clean it. The worse the recession gets as a result of the plaque-induced inflammation. And so minimal attached gingiva, thin friable tissues, aberrant frenum can cause discomfort when brushing. Localized accumulation of plaque contributes to progressive bone loss and progression of recession. Soft tissue grafting can improve mucogingival condition and comfort during home care. It's usually best to conduct a maintenance visit with oral hygiene instruction in these cases prior to soft tissue grafting. And so for these cases, I like to also just really coach patients on with all patients, I coach them on oral hygiene, but especially with these ones, I really like to make sure that we get the oral hygiene under control because it's really important that they keep the roots clean, especially before the procedure. So it helps to allow for manipulation of the tissue so it's not so inflamed when we do the graft. And so here's the initial presentation. You can see there's severe recession at 3-1. Tissues are thin. There's no attached gingiva. There's an aberrant frenum. There's an inability to perform oral hygiene at the site. It's very inflamed. The tissues are red, puffy, inflamed. And in this case, I performed a free gingival graft, and we can see before and after that we're able to establish a nice thick band of keratinized gingiva there, which is going to help with basically providing long-term stability for this patient moving forward. And we're also able to obtain substantial degree of root coverage. And here's another situation. I treated this case with a connective tissue graft. And so here we can see there's a lot of inflammation there. Patients not finding it comfortable to brush. You can see the frenum is right there. It's very difficult every time they brush, they're hitting the frenum. Their gums are really inflamed as a result there because of the recession that's present there, and it's difficult for them to reach the area and clean it comfortably. And so I performed a connective tissue graft with the tunneling approach. And we were able to obtain a much more stable situation where the patient's much more able to keep the area clean and brush it without having discomfort. Tissues are now significantly thicker there. You can see a nice thick band of tissue around all the teeth of the lower anteriors now. And here's the before and after. And then here's another case, similar situation. Isolated deep, you're oftentimes going to see this with isolated deep recessions. They're not able to keep the area clean because it just becomes very uncomfortable. So this was a severe recession at 3-1, thin tissue, no attached gingiva, aberrant frenum, so pretty much similar to the other cases that I'm showing you. This is a very common situation, inability to perform oral hygiene and inflammation. Here I also performed a connective tissue graft with the tunneling approach using microsurgical sutures. And at 2 months, we can see we're able to obtain substantial root coverage, tissue thickening, and an increase in keratinized gingiva. And you can really notice a pretty big difference between the initial and the after. And so now let's talk about the allograft and xenograft. And so are other options available besides autogenous tissue? Say you have a patient who's just absolutely mortified of having tissue harvested from their palate, and they're just not going to let you do it. And or there's a lot of areas of recession, and there's just quite simply is not enough tissue on the palate to graft all the areas that you would like to graft. And so the benefit of using allograft or xenograft is it basically allows you to avoid a second surgical site. There's less pain and discomfort during healing. And it also blends very seamlessly with the adjacent tissues, can be used for tissue thickening and root coverage, but it has the highest risk of recession recurrence, and any exposure of the graft can lead to infection or failure. And so here's a situation where a patient had generalized recession. I wanted to treat a multitude of sites in both the upper and lower arches. And so what I chose to do was to graft the upper sites with dermis and the lower sites with connective tissue grafts. And so here we can see what the grafts look like after I harvested them, and you can see what the dermis looks like. Here's the case after final suturing. And then you can see before and after for the upper arch, was able to obtain significant root coverage and tissue thickening. And then the lower arch, you can see this view right here will show you. You can see that the thickness now that we've obtained on the buccal aspects of the canines and premolars. Now there's a nice thick band of strong tissue there to help protect those the bone that's around those teeth moving forward. And so we've talked a lot about teeth. I mean, this isn't really the focus of the presentation, but I just thought I would include a couple of cases just for the, being complete. And so what about soft tissue grafting at implants? And so let's look at the peri-implant phenotype. So here we can see that what this is composed of is a keratinized mucosal width, mucosal thickness, supracrustal tissue height, peri-implant bone thickness. And so really we're aiming at treating the keratinized mucosal width and the mucosal thickness for the most part with soft tissue grafting at implants. Here we can see a case where I performed free gingival grafting. Here's the before and after. You can see that the patient beforehand had peri-implant mucositis with inflammation around their implants with plaque accumulation, inflamed gingival margin, thin tissues, lack of keratinized gingiva, and we can see the situation afterwards. And if you'll notice, there was actually some coronal migration of the gingival margin, such that there's actually less implant exposure after the soft tissue graft. So I was able to actually cover some of the implant with the graft, which doesn't usually happen, which was nice to see. And then here's another case. I didn't place these implants, but I was referred the case because there was going to be a stage 2 uncovery, and the tissues were really, really thin. And we were worried that basically there was not going to be a lot of keratinized gingiva around these implants to provide a stable situation moving forward. And so here I did a free gingival graft, and you can see after the free gingival graft was done and the healing abutments were placed, that we were able to obtain a nice thick band of keratinized gingiva around the implants of both the buccal and the lingual aspects. And then here's a case I actually did just this week. It was an immediate implant. Basically extracted the 1-1, placed an immediate Straumann BLT implant. And I decided to perform a connective tissue graft at the time of implant placement to help stabilize the soft tissue margin, and also to help provide a nice soft tissue contour at the buccal aspect. Once the final crown is placed, it's going to provide a nice convex contour. And so I secured this in place with a tunneling approach and some microsurgical sutures. And you can see here, I also packed some bone graft on the gap between the buccal plate and the implant. And then let's talk a little bit about some of the closing remarks. And so gingival recession occurs after bone loss. Thick keratinized tissues protect tooth supporting bone from trauma and plaque. Non-carious cervical lesions oftentimes require combined prosthetic and periodontal viewpoints for management. Mucogingival assessment is important when orthodontic treatment is planned or was conducted in the past. Autogenous tissue is the gold standard, but allografts and xenografts may be used, especially when treating multiple sites to limit discomfort during healing. Soft tissue grafting can help improve plaque control. These are really the main takeaways I'd like to leave you guys with. I hope you guys enjoyed my presentation as much as I enjoyed discussing this topic with you. And please feel free to ask me questions. I'm happy to discuss anything with you. And so thanks for your attention. Here you can see I provided my email address, and on the lower right there, that's my Instagram handle where I post a lot of my cases. Yeah, feel free to give me a follow if you'd like to see more content.
Yeah, that's great, Dr. Galli. Thank you very much. You provided a lot of variety there. And as a layperson, it's amazing to see how much improvement you can make in someone's situation. So thanks for sharing all that with us.
Oh, it's my pleasure.
So we have time now for questions. And Jake, what do we have there? Any questions so far?
We have one question in the chat box here. It says, when do you decide to do FGG or CTG?
Great questions, Sunita. And so FEG and CTG, in some situations, they can be interchangeable in terms of when I would decide to use one versus the other. The main factors that I use to basically decide is FGG, it's not going to be aesthetic. You're going to be able to notice it. It's going to look like you're definitely going to be able to see where the graft was placed afterwards. It's going to have more of a tire patch appearance. It is the most predictable way to increase the keratinized tissue width, however. So if we're just looking to increase keratinized tissue width in a non-aesthetic area such as the lower anterior, where a patient's not concerned about aesthetics, they don't necessarily mind if they notice the graft, then that's a very predictable way to do that. It can also be used for root coverage in areas that are non-aesthetic as well, but it's not as predictable for that compared to a CTG. CTG, the main goal is to increase tissue thickness, and also it's the gold standard for root coverage as well, and it's going to have a much more seamless blending in with the adjacent tissues. However, if you have significant interproximal attachment loss, root coverage is not really going to be predictable. So in those cases, I might be more likely to perform a free gingival graft if there's significant interdental bone loss. And my main goal is just to provide a more stable situation so they don't experience any more recession. I hope that answers your question. Please let me know if you have other questions. All right, so I see there's another one. Do you treat the donor site for, yeah, so I treat the donor site always for both pregingival grafts and connective tissue grafts. And I treat them in a similar fashion. So for connective tissue grafts, the way that I usually harvest them is a sub-epithelial connective tissue graft, meaning that I basically harvest just an inner aspect of the connective tissue, preserving the outer epithelium and a thin slice of connective tissue as well. I don't use the Harris knife, I just use a 15C scalpel. Basically just a normal blade, just a single blade. And I basically, my preferred technique is to do 2 parallel incisions. And basically I just dissect out an inner layer of connective tissue. And then I'll basically, the way I treat that is I'll put collagen tape, which is a collagen dressing to just help maintain some of the space, because otherwise the tissue tends to collapse quite a lot. It just helps to stabilize the blood clot. And then I also will suture with, usually use fluorochromic gut, and I'll do some sutures that basically wrap around the teeth and provide compression to help stabilize the blood clot. And then for a free gingival graft, the only extra step that I do is I basically oftentimes make a palatal stent, which is almost like an Essex, almost like Invisalign, but it covers the palate as well. So it just protects the palate, just because there's an open wound with the free gingival graft versus very close to primary closure for the connective tissue graft harvesting technique that I use. What's my favorite for stopping bleeding if it happened? So the best thing to stop bleeding is One of the best things you can do is to prevent it from ever happening in the first place. So you have to know which areas are safe to harvest from versus which areas are not safe to harvest from. Obviously, the main threat is hitting the greater palatine artery. And so really the main thing that I use to be cautious about this is how tall is the palatal vault. So if it's a really short palate, you know that the greater palatine artery is closer. You don't have as much room for harvesting. If the person has a really tall palate, tall palatal vault, then you have more room to harvest. Other thing is you have to be careful of the thickness that you harvest as well. The more if you're harvesting more superficially, you're going to be less likely to induce a greater extent of bleeding versus deeper. And then if bleeding does happen, usually the way I handle it is I'll have lidocaine with 1 to 50 epinephrine. It's a higher concentration of epinephrine, so it just acts as a hemostatic and vasoconstrictor. And that I'll put pressure, I'll put the 1 to 50 epinephrine, and then I'll just suture it very tightly.
I have another question for you, Dr. Galli. When is the best time to refer a patient for soft tissue grafting?
The best time to refer a patient is usually early. The earlier you refer them, usually is the better, because sometimes we don't even have to do the graft, but we can just discuss modification of brushing technique, which can help them to prevent them from ever needing the graft. If the patients are referred too late, sometimes then what can happen is it's just such a severe situation that it may be beyond what is predictably treatable. And so I would say the best thing to do would just be to contact the periodontist that you work with, send them a photo of it, discuss it with them. Feel free to call them up and discuss it. I think that would probably be the best thing if you're unsure about it. And don't feel like you need to have all the answers about it. Sometimes it's good just to consult with other people and run things, and we can all discuss things with each other. And even if it's a case I'm not directly involved in, whether you're referring it to me or not, you can always reach out to me if you have a question about it, and I'd be happy to answer it for you, or sorry, to discuss it further with you. Um, do you remove the epithelium and thin the graft or just epithelium? So that question is really aimed if you harvest a pregingival graft and then you're going to want to use it under a flap with a bilaminar technique. So you're going to want to do like tunneling or a coronally advanced flap over the graft. Then you should remove the epithelium. You should try to harvest grafts that are not too thick. Number one, it's going to be less uncomfortable for the patient during the healing. Number two, it's going to be easier to advance the mucosa over it. And so kind of the sweet spot is between like maybe around 1.5 millimeters, I think would be a good place to aim for the thickness of the graft. And then what is your opinion on the 1D? I think it's probably pretty difficult to learn everything you need to know about soft tissue grafting in 1 day. It's a pretty nuanced and technically challenging procedure, but I think it's good to also um, do new things and try things to if you're interested in doing it, you should take courses on it and learn about it. And so I would be supportive of it, but I'd say it's difficult to learn everything you need to know in just 1 day on this topic.
Dr. Galli, we had a couple questions that came in before the presentation too, so I wonder if you have a chance here.
Yeah, for sure.
First question is, sometimes patients complain of sensitivity associated with recession. Does treatment of recession with soft tissue grafting eliminate sensitivity?
Yeah, that's a good question. It's a common situation where patients are referred, they have sensitivity, and they're wondering if soft tissue grafting can help eliminate it. I'm hesitant to ever promise a patient that soft tissue grafting will eliminate the sensitivity. Usually, the way that I describe it to them is that I'll say that if the recession gets worse, the sensitivity will get worse. The reason you have sensitivity is because you have recession. You have loss of the bone and gum tissue around that tooth, and it's exposing part of the tooth that was previously covered by gum. And so soft tissue grafting will help to stabilize the gingival margin to prevent it from recession from progressing further, but it may or may not reduce or eliminate the sensitivity. So that's kind of the way that I word it.
Mm. Now, one other question here that seems important, at least to me as a patient. Do you have a preference for manual or electric toothbrushing?
Yeah, that's a great question. A lot of times patients they think, oh, I switched to the electric, and they're kind of like thinking like, oh, that's going to be inherently better. I will say that the electric may be inherently better for patients who have issues with manual dexterity and things like that, so they can't use the manual toothbrush. But there's nothing wrong with using a manual toothbrush as well. I think the main thing is that you can do a good or a bad job with any sort of tool. And it's less about the tool and more about how you use it. The only major thing that I would say is that you want to have soft or extra soft bristles. And just following the tips that I outlined previously, it's a toothbrush, not a gum brush. Gentle touch, gentle pressure. If you're using an electric toothbrush, let it do the work for you. Just trace around the gum line. Don't add in any additional force or scrubbing motion. And just overall being gentle and realizing that your gums are a delicate biological structure and you need to treat them with respect and be gentle towards them to prevent them from deteriorating over time.
Excellent. I think
Looks
that's all
like
the
I
questions, Jake.
I have
or-
one more question for Dr. Galli here.
Okay.
What do you think are the limitations of the pinhole technique?
That's a great question. And we get that a lot. The pinhole technique is basically a way of doing soft tissue grafting without harvesting autogenous tissue, and you're not using any sutures. I think the main limitation of it is the fact that you're not using any sutures to stabilize the graft, and graft fixation and graft stabilization are really, really important concepts in soft tissue grafting. If the graft isn't stabilized fully, it's not going to have as good of a chance to integrate with the surrounding tissue. You really have to make sure that the graft is super stable and fixated. And so that without sutures, I don't see how it's very easy to do that. And also, like I was mentioning earlier, autogenous tissue is the gold standard. It has your own cells in it. And so it's much more likely to integrate with your surrounding tissue versus I think with the pinhole technique, mostly you're using collagen strips or you're basically pushing them into a hole that you make in the apical aspect. It can have some good outcomes. I've seen some good outcomes from it, but I wouldn't say it's the most predictable way to treat a lot of these cases.
Right.
Yeah, that's about all the questions I have.
Okay.
Thanks, Mary. I saw your message. I'll say hi to him for you.
Friendly crew. All right, Dr. Galli, thank you very much. It's been great. You shared a lot of your insights and knowledge, so we thank you for that. And I hope that your colleagues were able to gain some new insight into approaches for soft tissue grafting as well.
Oh,
Just a
thanks.
reminder that if anyone has further questions for Dr. Galli, feel free to contact him directly at his email, drmattgalli@periocare.ca. That's Dr. Matt Galli at periocare.ca, or through TMFD, and we'd be happy to help. So as we close up here, I'd like to thank everyone for joining us this evening. We hope you enjoyed it. In the days following the webinar, video recording will be posted on our website, tmfd.ca. You'll also receive a brief survey asking how you enjoyed tonight's presentation, so please share your feedback. And please tell your colleagues about TMFD Dental Academy. We'd love for them to join and gain from the collective knowledge that's out there to be shared. A reminder that PACE credits will be issued within the next 2 weeks. TMFD will be hosting additional webinars later this year, so please watch for these announcements in the days ahead. So as we close up, I'd like to thank our speaker, Dr. Matthew Galli, for his valuable expertise and insight, and to Jake for running the show. And of course, thanks to you, our guests. It's been great to share this evening with you. We hope you found it very valuable. Thanks again, and have a good night.